My name is Victor Chow. I'll be giving your next lecture, Provider Recruiting and Staffing. It's part of the Comprehensive Clinical Startup lecture. I'm currently the assistant. Can everyone hear me? Higher. Okay. Everyone can hear me? No? Better? Better. Good. Can everyone hear me okay? Heather, it's good? It's okay, Heather? Okay. I'm currently the Assistant Medical Director at Lake After Hours in Baton Rouge, Louisiana. We operate 11 clinical sites in the area. I've been with Lake After Hours for 7 years. Currently the Assistant Medical Director. We have over 100,000 patient visits a year at our various facilities. No disclosures that I have to report. Okay. All right. Thank you. No disclosures that I have to give. These are some of the objectives, but there's actually a much longer list later, so we'll go with that. The previous lecture, or other lectures you've gotten, they've talked about the importance of having a good location, insurance contracts, all of that. I totally agree that all of that is important when you're deciding where to put your clinic and to get people in your door. However, once you start seeing patients, your success or failure will be determined by the quality of the care you give. I'm in charge of dealing with complaints for our company, and for over 100,000 patient visits a year, we average less than 50 actual patient complaints a year. People will remember one thing. They'll remember how they were treated. Of all the complaints that we get, 80% are easily about the care. So take special care in deciding who works at your clinic. Now, as I told you, we have a unique circumstance. We operate 11 clinics in a certain area. If you're just starting a clinic, if you only have one or two, you have to, pay, special attention to that. And the difficulty of hiring is that unlike, say, a clinical practice where you have guidelines, this is how you treat strep throat, this is how you diagnose it. As far as I know, there are no guidelines as to who is going to be a good physician in our practice. I wish there was a computer program that I could go in. I could tell them what my patient demographics are, what my average patient income is, the age of my patients, and it could split out a laundry list saying, you need a female provider, Caucasian, age 25 to 45. I wish I had that, but we don't. So we're going to go through these things through the course of the lecture. I would ask if you have any questions. I do reserve about 15 minutes of time at the end, and we can also go in through the break time as well if any of you have questions. So let's go down through this list, because to me these are the 8 most important characteristics that you look for in your provider, but not 8 are equal. So I want you to raise your hand. I'm going to work my way down. Tell me which the most important one out of all of these characteristics. If you think that your medical knowledge of your provider is the most important out of these 8 things, please raise your hand now. If you think that your bedside manner or the patient satisfaction or your ability of the provider to provide that is your most important characteristic, raise your hand. The knowledge of billing and coding, as far as they know how to code, they know what that type of stuff, who would rate that the most important thing? Couple hands. Works efficiently. So I describe that as being able to see a reasonable number of people an hour, minimizing the wait time, things like that. Who would rate that as the most important? Couple hands. And then we're going to lump the last 3 together. Computer skills, being able to supervise your staff, or being well liked by your staff. If one of those 3 is the most important, raise your hand. Okay, good. So again, this is just my opinion. I've already ranked this in the order that I feel is the most important. So you can see how I've differentiated the top 4 from the bottom 3. Ideally, if you can get a provider that has all of these characteristics, wonderful. But if not, work your way down. Now, I have noticed, and this is where I'd like to get sort of an opinion. How many of you in this room are physicians? Can you raise your hand? Okay. How many of you in this room are nurses, administrators, or come from that type of background? Raise your hand. Good. Okay. This was actually a little bit of a surprising crowd because my first two, typically when I give this lecture, the physicians in the room always rate medical knowledge the highest. The administrators and people that are not physicians always rate the bedside manner and the patient satisfaction higher. And again, I'm not here to lecture you on this is what you absolutely have to have. More, these are the things to consider. I will tell you at Lake After Hours, the medical knowledge and the ability to provide the absolute best medical care trumps everything else. If it takes longer to process the patients in and out of our clinic, we accept that. You know, if we do not prescribe an antibiotic to a patient and they're going to be upset by that, so be it. Okay, so like I said, these are the 4 that I would rank the highest. Okay, let's talk about specific provider traits. And in my experience, we have about 40 to 50 physicians that work at our locations between part-time, PRN, all of that. I've personally trained over half of those physicians, and I've personally recruited about 25% of that. So these are sort of my general interpretations of, what I think are important. The previous experience, in my opinion, is the #1 factor. If you can find a physician that has previous urgent care experience, that will probably be the best determinant as to whether this physician will work well in your practice. It's been true for us. However, you got to make sure that if you're recruiting someone from a different urgent care, that the demographics and the style of their practice match yours. Here's some pitfalls that we've had. For example, our clinics are mostly 8 hours. We have a couple that go 12 to 14 hours. I've had some physicians that can work great for 8 hours. When you put them into a setting that are 12 or 14, they get fatigued. They start dragging at the end. The customer service starts to go down. Some doctors work really great with your upper middle class patient population. For some reason, they don't work as well with a working class population. So those are all factors that you have to take into account. I've seen some urgent cares where the physicians are responsible for starting IVs, otherwise no IV fluids get done. Well, if your physician has not started an IV, and that's something you neglect to mention, you are losing a large potential part of your visits and reimbursements. And then, you have some people that are great doctors. They're just not good administrators. They're not good at marketing your clinic. So if you're looking for someone that's, say, a medical director, you need someone that's going to go into your community, work with other practices, go, bang the doors, basically, to recruit patients for your practice. So let's say in your area you're going to be the very first urgent care, or the other urgent cares are not very good. That's why you're entering this market. Okay, great. Well, where else can you recruit physicians from? Our tendency is that we otherwise get physicians from a sort of an outpatient family practice background. We have some of our physicians that come from an ER. I would say the rest, I would consider them sort of miscellaneous. So family practice doctors, for those of you that aren't familiar, I hope I'm not going too basic, but in their training, they're equipped to see a wide variety of patients, babies, adults, elderly people. So I found that for us, for an urgent care, these providers generally have the best skill set as far as matching the type of procedures that we do in an urgent care, things like that. However, be careful. Just because you have someone with a family practice background, and we've fallen into this trap ourselves, at most urgent cares you're going to do x-rays, right? Well, who interprets those x-rays? The doctor. Your family practice doc may not have looked at an x-ray since residency. They may not do sutures and procedures, or they may have a rule in their practice where, I don't see kids less than 6 years old, which is typical of some family practice doctors. So you need to think about that. Also, one of the main problems is your family practice docs tend to start out really slow because they're still in the mindset. This is my patient. This patient has 5 different issues. I need to handle all of these 5 different issues, plus make sure their diabetes, high blood pressure, and cholesterol are under control. That's not what you want to do in an urgent care, so you have to find people that you can either train or get out of this mindset. What about finding doctors from an emergency room? We have some providers that come from the emergency room. You know, it's plus or minuses. Number one factor is your emergency room doctors are going to want to get paid a lot. They're going to want to get paid comparable to what they earn in an ER because they have that skill set. You may not be able to do that. So that, what I found, is usually our number one reason and why we don't recruit a whole lot from this skill set. I have found, though, one of the pros is that ER doctors are great at not caring about any of the other stuff besides what did you come in for today. And so most of them I found are very efficient. They're able to work through the patients pretty quickly. If you go down through cons, look at number 3 and 4. These are the two biggest issues that I've found. Number one is some doctors in the ER like to do a lot of tests. They like to CAT scan everyone. They like to do blood work on everyone. Most urgent cares, you're not going to have a CAT scan, or as far as we don't. You're not going to be able to do a lot of stat blood work. If you have a doctor like this, and we've had a couple, basically every other patient, he's saying, oh, I can't treat you here, go to the ER. You're going to piss off a lot of your customers very quickly. So you have to make sure that your doctor hasn't been, how should I put it, over years of being in the ER, just gotten used to being able to do all these tests. And I found some doctors in the ER have a problem with the bedside manner. Remember, urgent care, it's a retail business. It's no different from operating a restaurant. You want your patients to be happy. You want them to come back. I found a lot of ER doctors are just sort of short, gruff. You know, it works great for the ER. It's not good for a retail business. If you're new to the urgent care field, honestly, I wouldn't even consider any other backgrounds, especially if you're not a physician, if you're not a medical director, because it's really hard just sorting through family practice and ER docs, people that should have your skill set. It's already hard sorting through that. Now if you start throwing internists into the mix, do they even know how to take care of kids? You know, people that do occupational medicine. Now if you have a particular audience, let's say you have a lot of geriatric patients and you don't have any kids in your practice, yeah, sure, internists might be great. If you see mostly workers' comp, okay, someone from an OCMED background. But unless you're very experienced at filtering out, I really wouldn't even consider these backgrounds. Okay, this is always a touchy subject, and I always get one or two people that are upset at me for even suggesting, but I'm here to just give you my honest opinion based on what I know. The younger the person, the better. They're up to date on computer skills. They're able to work longer shifts. They're able to work faster. They don't, well, it depends. Younger ones, like people straight out of residency, if they're single, they don't have kids. So they're not telling me during spring break or summer vacation, oh, I got to have this week off. Oh, we're taking a trip here, taking a trip here. You know, now, I will be honest, we've had a lot of good success with people that are semi-retired in their 50s and 60s that, you know, just work with us a couple times a month. You know, they're pretty reliable. But I'll just leave it at that. Men versus women. Most of my complaints from patients come from my older male physicians. Why? Because only recently have physicians been trained to think of patients and incorporate them into the medical decision making. Older doctors trained where basically I'm the doctor, you're the patient, you listen to me, and if you complain, too bad. So vast majority of my complaints come from my physicians over 45, 50. On the other hand, my women are the ones that, oh, my kid's sick, I got to take off. You know, they're the ones that have a spouse that makes just as much or more than they do, so the work may not necessarily be a big financial motivation from them, you know, so they can sort of take it or leave it. And then I have found that, for example, if you have a large Spanish-speaking population, if you have a provider that speaks that language, or whatever language it could be, it's much more efficient than having a nurse or an x-ray tech that comes in as an interpreter. It takes twice as long. That nurse or x-ray tech is not able to do what they should be, which is taking x-rays or giving shots or making your clinic money. Okay, so as far as the provider demographics, urgent care experience is preferred as long as the practice settings are similar. Otherwise, you want someone that comes from a family practice background. And they must have lost one of my slides, but I guess I had a slide in there talking about goals. In summary, I guess I can say, if you have a provider that comes in, they're established in the community, that is a provider that you can count on versus someone that's, more of a locums that just, works a job every couple months and goes to another job and something like that. Okay, so let's consider your clinical factors. We've talked about providers. What do you look for in a provider? But what about the clinic? Because the way you set your clinic up will determine what type of provider you can get, and it may have some influence as to what you're looking for. Okay, so these are things we'll go through. So when I talk about an urgent care, unfortunately everyone sort of has their own interpretation. So for me, my definition of urgent care is a clinic that sees walk-in acute patients. Maybe some clinics take an appointment, that's fine. Open, 8 to 18 hours, but not 24 hours, not open overnight. There's no advanced imaging in the facility, so you're not asking your doctor to look at CT scans. You're not asking your doctor to interpret ultrasounds. And it's not obviously a specialty clinic. I've seen some urgent cares where they do Botox in the clinic. So obviously, if you have any of these special factors, you have an even more narrow subset that you're looking for. How many locations do you have? The type of staffing that you do really will be determined by how many locations that you have, especially if you have multiple locations. If you have a single location, not a big factor. But one of the big question marks our company has dealt with over the past couple years, and honestly, we have no we still don't know, is do we keep 2 providers at one location and have them flip-flop their schedule and make their schedule internally, and we just tell them, hey, you 2 work out everything, as long as you have every day of the month covered, we're happy with that. That's what my wife does. She's a pharmacist. Her and her counterpart, they set their schedules. As long as everyone's happy, that's good. Or do you have your physicians rotate amongst the different clinics? Well, there are pros and cons of each. Patients like it when they go to a clinic and they know there's 1 or 2 providers there. They have sort of a continuity there. They get to know people. The problem is your physicians start thinking of this as my clinic. And if someone else at the same company can't staff theirs, they're sort of like, oh, well, that's not really my clinic. I don't need to worry about that, which is the same issue my wife has with her pharmacy. The number of hours you're open is a big determinant. If you're open 8 to 12 hours, you can generally staff one location with 2 doctors. Once you're open longer than that, you may need to consider adding on a 3rd doctor and splitting that shift up. So that's just something you want to consider. Most of the doctors I work with, they like working a longer shift. So instead of working 8 hours, most of the doctors I know like to work 10 or 12 hours. But you never get anything for free. In trade-off, they don't want to work as much. So, I have to find another doctor, to replace it, because they'll say, okay, well, if you had me working, 5 shifts a week, 8 hours a week, I'll work 3 12s, but that's all I want to do. So you've just lost 4 hours right there. Patient volume. Now, I go to this conference a lot, and when I throw this number up, the very first response that I get from most people is, my God, that's all your doctors do? I hear of some clinics out here that they see 5 or 6 patients an hour for the entire length of the clinic. And again, I'm not here to judge how you run your clinic, but I found once you start asking your doctor to see more than about 3.5 an hour, and again, this is sort of averaged over the length of the clinic. So an 8-hour shift, you might be talking about 28 patients. A 12-hour shift, you might be talking about 40 patients. Once you start going more than that, number one, I found the patient complaints go up dramatically because they're waiting longer. Number two, the patient's complaints go up because they feel the doctor didn't spend enough time with them. So again, I'm not here to tell you how many patients is ideal. We found that this is ideal. Plus, again, it all is determined by, the stamina of your provider. We have some semi-retired providers that probably couldn't go much faster than this. So, I'd be beating a dead horse if I told them they had to go faster. And then you want to think about your patient demographics. A good doctor, the first question they shouldn't ask you when you're talking with them about working at your urgent care is, how much am I going to get paid? If I meet with someone and that's their first question for me, they're instantly dropped down to the bottom of the list. Because for those of you that are doctors in this room, we make a good living. I don't think anyone will argue with that. But how many of us think of that as our main or only motivation? We care about what type of environment we work in. Are we able to provide good care to our patients in this environment? If I just see them, am I just putting them in the street, or do they have some type of follow-up? So a good candidate is going to ask you these type of questions. Do we have an ER for someone I can't treat at the urgent care close by? Are there primary care doctors that I can refer patients to follow up? So these are questions you need to ask yourself and have answers for. Again, knowing what percentage of patients you have that are kids, what patient percentage are elderly, things like that. You need to know that. And then probably along with this list, you have to decide, are you hiring a medical director, someone that's going to see patients, and then if you're not a doctor, if you're a nurse or an administrator, help you administrate the clinic? Or are you going to be the medical director and you just want to hire someone to help work the shifts you're not working? I will say this, I've met many people in this conference, and again, I don't know any of you, and I've had some people that come up to me and say, Dr. Chow, I really liked your lecture. I'm thinking about starting an urgent care and this. And I can instantly tell that urgent care is not going to be successful. So this is the time, if you're a doctor and you're thinking of opening or being your own medical director, look at yourself. Or do you have the right characteristics? Are you patient-oriented? Do you have the patient knowledge? If you're going to be operating this clinic, do you have the right financial background, the right mindset, that type of stuff? So ask these questions. If you're looking for someone to serve as a medical director, I found that a lot of times someone with that previous experience, so someone that's been chief resident at a residency program, tends to do good at juggling, scheduling at multiple sites. I've had a couple people that came from a solo practice where they were just on their own, and you ask them to manage a group of people, and they fall flat on their face. And then you also want to look at what your competitors are. So everything that I've said so far, there's this one saying that, wrong slide. I'm sorry, I went too far ahead. Keep in mind that it's not just urgent cares, but it's other practices that are also competing for your patients. ERs, primary care offices. If you can, some jurisdictions allow a non-compete. So if your hire is willing to sign that, but then on the other hand, some providers, the instant you bring that up, they walk straight out your door because they know they're a valued commodity. So the services that you offer determine what type of provider you recruit. Again, what hours you're open, you need a certain type of provider. Your patient demographics, you need a certain type of provider. But I will tell you this, I have a lot of great providers in my practice. Some of them aren't the best at seeing little kids. Some of them aren't the best at, suturing. But they have great personalities, the patients love them. Sometimes it's wiser to lock up that physician and just say, well, do we really have that many kids below the age of 6 months? If not, then fine. We don't need to see those or whatever. Okay, let's talk a little bit about recruitment strategies. Where do you find these providers? How much do you pay? Big question I get asked a lot is, what about PAs and Ps? Should I use them? We'll go through all of this. So as I spoke before earlier, I find that people that come from an urgent care background do the best in our setting. But we've used all of these methods to try and find our recruiters. Now again, to find our providers. Now again, keep in mind that we have 11 clinics in Baton Rouge. We're the largest provider in Louisiana. So people come to us Whereas if you're a solo location without a hospital brand or a hospital partner, you might be having to go out and looking for people. So just keep that in mind. Our experiences may vary here. So for those of you that don't know, Willie Sutton was apparently a famous bank robber, in the 50s or 60s. When they asked him, why did he rob banks? His answer was, because that's where the money is. Okay, if you're recruiting for an urgent care, find doctors at other urgent cares. That should be your first method of action. That's how our competitors in Baton Rouge poach doctors from us. They see we're a successful company, we must have good doctors, come grab our doctors. So you do the strategy in reverse, just not in Baton Rouge. So again, we discussed why. Because of the skill set and then the work environment, So what I would recommend, again, just don't do it to us, is when you call up the clinic, most of the time they'll tell you who the doctor is. Just pretend you're a patient. Hey, I was wondering who the doctor was. I had great experience with someone a couple weeks ago. Okay, and then you find out when they close, and then you go sneak up to the employee entrance, and then you find the doctor. You said, hey, I'm recruiting for this. Here's my card. Okay, will they be happy? No, but that's how you do it. Another way is find out who the solo practitioners are in your area. Solo internists, solo family practitioners. Because of many reasons, I'm sure many of which have been discussed in this series of lectures, many solo practitioners are closing up shop. And you call or drive around, you can oftentimes find out who your solo practitioners are. And sometimes if you just go up, and honestly, that's how we've gotten a couple of our very good doctors. We just say, hey, look, you have a lot of overhead here. You're not making a whole lot of money. You have a great reputation in the community. Why don't you just come work here? We'll pay you an hourly salary. You don't need to worry this overhead. You don't need to take call. We've had great success doing that.
How appealing is the urgent care setting for someone coming straight out of residency and is approaching residency programs and schools and stuff, and approach what they do?
I have that in my next slide, so I'll go through it right there. There we go. So his question was, if you are fortunate enough to have a residency program in your area. So if you're in a metropolitan area, even smaller communities I've found oftentimes have family practice residencies. How good is your recruiting there? So I want you to think when you're talking about residents in two separate things. I want you to think of just having someone that's still a resident that's working at your clinic for extra money, that can sub on a weekend to get your regular doctors some time off to go to a baseball game or something like that. Great. That's how we use our residents. And it's also good because most of them don't want that much money. For a lot of them, it's just extra spending money. They only make $15, $20 an hour. So if you offer them $65, $70, they're ecstatic. They'll drive an hour and a half to come work with you. And the perfect thing is there's time that you want their services on the weekends is the time that they have available. So it's actually flip-flop compared with your normal average doctor who wants their weekends off. Depends on the state. Depends on the state. So some states allow residents to moonlight after their first year residency. Some states, they have to have 2 or 3 years. Almost all the time, if they're a fellow, they already have that. So yes. And another thing is, it often becomes a pipeline. If they like working with you, they'll recruit their fellow residents. So you have this recurring pipeline. I would say of all the time that I've spent recruiting, going to residencies has been the thing that has paid off the most. However, I'm going to just be perfectly honest with you. I've had a hard time converting many of those moonlighters into full-time jobs with us. And I don't know why. I will tell you that a lot of the residency directors, their bosses, are okay with them moonlighting. But when they start to, look at jobs, for some reason, the urgent care field, perhaps because it's not as established, is less prestigious. So they'll get a lot of, conversation with their residency director. Yeah, do you really want to go into that? That's not really a real job, and this and that. Wouldn't you just rather have your own family practice? Or for ER doctors, I hear much the same from them. They say, urgent care, that's what old ER docs do when they die, something like that. So, you have to keep in mind that they may not necessarily come to your practice and work full-time. So emergency rooms. So again, the only problem with emergency rooms is a lot of times you don't know where the doctors are coming and going from. And you're certainly not going to spend $1,000 to go pretend to be a patient at the ER just to talk with someone. So, a lot of times, again, for us, people come to us. I'm not really sure, honestly, how you would recruit someone from an emergency room background, to be honest with you. But I have found that some doctors, like I said, the quote, urgent care is where ER doctors go to die. Well, you might have someone that's 40, 50, they're burned out, they don't want to be doing traumas and CPR every night and all that, and they may be willing to, take a job at your clinic. The last 4 we've tried, we've had little to no success with these. And again, your mileage may vary. We found with the recruiters, all they care about is making their upfront fee. They just drop a guy in your lap, collect their money. They've all been crap. Staffing agencies, we've actually not used any, but I'll be honest with you. I have staffing agencies call me all the time. I would not consider working for a single one of those. So if you have someone that's coming to you from a staffing agency, you have to ask yourself, why can they not get a job through a traditional channel, through just a personal contact, things like that? And then we send postcards out and direct mail out, and they all get returned back. Just save your money. Okay, so how much do you pay? That's another question I get asked. This is like saying you can buy a car for $10,000 or $50,000. It really just depends on where you are, what the need for physician services is, and just the volume of your clinic. So I've heard anywhere from $65 to $150. I'm not necessarily using this as a guide for you, but because I do get asked. And then some people ask, well, do you pay them as an IC independent contractor? Are they an employee? What I've found is that there may be some doctors that really care one way or not or another, but it hasn't made or break the relationship. But on the other hand, at Lake After Hours, we sort of give the doctors their choice. So, and then most providers do expect that you'll pay their malpractice insurance. So keep that in mind. Okay, so now you've recruited them, you've identified someone. I always, 100% of the time, have them fill out an application. And you may say, well, I just had talked with this guy, he comes well recommended. No, every single person fills out an application. And the reason why is we used to have a lot of turnover with our new people. And we figured out that we were making it too easy for them. They didn't have to provide any commitment other than to tell us verbally, hey, I want to work with you guys. And so we'd sign them up, get them on our malpractice, get them credentialed. And then when we actually go back, they didn't want to do any shifts. So I have found just a simple 5-page application eliminates 90% of that. Because if they're too lazy to fill out a 5-page form, then how interested are they going to be working at your practice? Interview everyone. People come in great on paper. And then when I bring them in for an interview, they won't look me in the eye. They're looking down like this. I can barely hear them. That's someone that's not going to do really well with your patients. I've also found if you have an MD interview this patient, you're going to be better off for it. That's why I interview everyone. I've had people come in highly regarded where my nurse managers has interviewed or someone in our HR department. This person comes in with flying colors. And then I say, do you do your own x-rays as far as interpretation? Oh, I really haven't done that in a while. When's the last time you sutured? Oh, in residency. For some reason, with me sitting in front of them as a doctor, they don't BS me as much. Okay, so if you do this interview, they may say, oh, I'm comfortable with kids, I'm comfortable with this, I'm comfortable with that. They're comfortable with everything. And then when you sit them down, the truth comes out. Please call and verify all references. I know that's sort of a standard HR procedure. As doctors, we sort of give each other sort of the benefit of the doubt. No, I call everybody. But I make sure that I ask them about the things we care about. How's their bedside manner? How's their speed? How are they as far as we get a lot of patient complaints? And then when they go through their insurance credentialing for the malpractice, a lot of things will come up. Well, hopefully not, but those type of things will come up there. So if I have one piece of advice, and you're a single unit operator, you're not affiliated with a hospital brand or something like that, and someone just sort of pops in your door and says, hey, I'm Dr. So-and-so, are you looking for a doctor? I'd be willing to work for, minimum wage or whatever, and you're ecstatic. No. Think back. I'm sorry, you're a small operation. Why would a legitimate doctor come to you looking for work? For us, we're the biggest operation in Baton Rouge. It's understandable. We have a lot of primary care that we're affiliated with. But again, it's just look at it honestly from the other side of the fence. It's just like when that person comes and says, I got a great deal for you on swampland or whatever. So really think about that. And then here's one thing too. Again, being perfectly honest. What's your competition? If you're going into an area that has a lot of urgent care already, your location is important, the quality of your provider is important, but honestly, if you're going into this bodunk rural area that has never seen a doctor in the past 20 years, you could put, Billy Bob Hillbilly MD, and you'll probably be successful. So again, what's that saying? In the land of the blind, the one-eyed man is king. So again, I'm not telling you how to do it, just my honest opinion. Okay, PAs and NPs. You can see my answer there. I work with a lot of PAs and NPs. In fact, we are the second largest employer of PAs and NPs in the state of Louisiana. But would I ever hire a single one of them if I was in the position of staking my life, my livelihood, my business on one of them? Absolutely not. They're not appropriate for someone starting a clinic, especially if you are not a doctor. They're going to come to you and say, oh, well, I only need to make $50 an hour, And you think, ooh, that sounds great. But when you add in all the costs, PAs and NPs, for most states, they need to be supervised by a doctor. So now you got to find a medical director. You got to find a medical director that you pay to sign charts, to review charts. If you get a complaint, that medical director's got to look at it. You get lower collections for having an MP and a PA. And most of the ones that are going to make $50 an hour are straight out of school. So who's going to train them? You can get experienced ones from the ER, but they want just as much as hiring a doctor would. Now again, if you have someone that's really that good, that experienced, okay, maybe it's worth it. But I have found that, honestly, for patients, here's one big factor. Who's doing your front desk? I've had a lot of patients call and they say, hey, who's the doctor day? Do you have a doctor day? And the front desk, even at our clinic where a lot of our staff have been here for years, they'll say, yeah, we have a doctor day. And guess what? It's a PA. And guess what? State law says you can't tell a person they're seeing a doctor when they're seeing a PA. I'm sorry? So, are you violating some type of law if the patients come in thinking they're seeing a doctor and they're seeing a PA? At the very minimum, they might be upset by that. They may demand to see a doctor and you have no doctor there. Now, did I have it here? Okay. I did say one area that it is good is if you find that you have so much business, which is a good thing, that you can't have one doctor handle it all, then yeah, hire a PA to see some of those overflow patients. So you have a doctor and a PA at the same time. Then your PA can bill what the doctor bills. Your patients are happier because you're getting the patients in and out quickly. And if a patient says, no, I don't want to see the PA or the nurse practitioner, then fine, the doctor sees them. So that's a good strategy, and I use residents the same way, especially some of these residents, Monday through Fridays, they have their day jobs. And some of our clinics, because of the way we're open, are busy around 5, 6, 7. And the residents just come, work in a couple hours, help with the overflow. They're happy, we're happy, it works great. So all physicians should go through a thorough application and interview process. Residents are a good choice for PRN work, and do not use physician extenders as your primary provider. So staffing strategies. Okay, so again, these are just sort of calculations I've made just through the years. For one location, utilizing one physician a day, your max shift is going to be about 10 to 12 hours. I know some clinics are open 14, 16, 18. It's really too much for one doctor, in my opinion. So if you assume a 10 to 12-hour shift to cover 7 days a week, you're probably going to need 2 full-time physicians. But remember, your physicians, they're going to get sick. Their kids are going to get sick. So you have to have someone in backup, otherwise your clinic is closed. Now, if say your shifts are shorter, then you can probably do a variation, maybe 1 full-time, 3 part-time, or things like that. Okay? Weekends will always be your hardest shift to fill. So when you staff, you always need to keep that in mind. And you will need standby providers for emergencies, so you have to have a backup. It's the same problem my wife gets into with her pharmacy job. There's 2 of them, no backups. So if one patient gets sick while the other's out of town, what do? Now, I found that even though we have 11 clinics, we actually don't need that many standby providers. So it's not like, if you have 1 location, you need 1 standby. You have 5 locations, you need 5. A lot of times you have 1 location, you need 1 sort of standby provider. If you have 5, you might only need 2 or 3. So it's not necessarily a linear equation. So we talked about this. I found that the best thing is have a mix of full and part-time providers. Because some people, they see it as a career path. Some people, they just see it as something so they're not bored in retirement. And I find that when you sort of have a mix, I think that works better. Because if you have all full-timers, we've already talked, well, what happens if you have an emergency? Well, if you hire 3 full-timers for a week, there's someone that you're overpaying not to work, or you're overstaffing. If you have all part-timers, they're sort of transient, they're semi-retired, they're not as invested in the business. So, I found a mix of full-time, and then your PRN providers work well. Know what your providers want before you hire them. This is a big problem for us. Where we hire people, there's a miscommunication. For some reason, the provider thinks they're going to get all Monday through Friday, 9 to 5. That's not what we do. For some reason, somewhere in the application or the recruiting, they got this mindset. So I always clarify with them. Say, this is what you're going to do. You're going to work 4 weekend days a month. You're going to work 10 weekdays. Your shifts can be a mix of 3 p.m. to 11 p.m., 9 in the morning. Be clear on that, can they just call you and say, oh, I'm sick today, I can't come in? Whose responsibility is it if they can't come in? So, and then as we said earlier in the interview, what is your actual skill set? Do you know how to do suturing? Do you know how to? These are hard questions that I ask. And I found that doing the hard work at the beginning saves us plenty of time at the end. And then we talked a little bit about the sort of volume and peak volume, sort of the numbers that we look for at our clinic. Again, I'm not saying these numbers work for everybody, but this is what we have found to work the best in terms of patient flow, in terms of cash flow, in terms of patient complaints. All right, great. So I sort of threw these in. They're not technically part of the recruiting and staffing in this so much as, obviously, if you're recruiting for a new location, if you have a new clinic, great. But some of you have established clinics. You have physicians that aren't doing so well. You're thinking of replacing. So these are the questions I get asked a lot about, are these circumstances that I need to find a new physician? And for most of these, the answer is no. Yeah, if your physician doesn't show up, comes in late, closes the clinic early, rude to your patients, absolutely. I would say get rid of them, doesn't know what they're doing. At our clinics, some of our clinics, we have what we call lead physicians. So these lead physicians, because they're responsible for a little bit more, they're responsible, for reporting when the clinic is not in a cleanly situation. They'll be responsible for following up, making sure all labs, x-rays come back to the right place. They get paid an additional bonus every quarter. So those are what I would say are 3 common things that we do. Yes, sir.
Question going back to what you mentioned before. One, you said that you could be hiring internists in the area, for example, established internists.
Yes.
You work with semi-retired or something. If he asked you, for example, if he could see his own patients during those hours. The second question is, you mentioned also that some doctors might not be feeling comfortable in treating kids. I thought it was just either all or nothing. I mean, either you take kids or you don't. What do you do if the doctor's on staff at that time and if a kid walks in?
Okay. What was your first question again? I'm sorry. The internist. Okay. We have the benefit of having done this for over a decade and with over the number of doctors we have. So we have a little bit better scrutiny of what works with us. Now, I also will say we do have one clinic that's split. One half sees only adults and one half sees only kids. So the kids portion is staffed by a pediatrician, and then the adult portion is staffed by an internist or a family practitioner. So that's sometimes where we will put an internist. But again, that's only one clinic, so that really can't be a full-time thing. What I pretty much tell them, at least with us, again, we're sort of in a position to be demanding. We say, well, you either learn it or you're not going to work with us. Now, because of the way we're spread out, and I've done the schedule for a long time, I know which of our clinics see a lot of kids. For example, we have a clinic by LSU, our state university. It's all 18 to 26-year-olds with runny noses. They stayed out too late. They're sick. They're drunk, whatever. There's no kids at that clinic, so I'll throw my internist at that clinic. So again, sometimes you have to strategize a little bit. And then you had a second question.
Would you allow this internist that you hire to see his own patients
Okay.
in continuing care?
Okay, and I will say also, we do have an extensive training program that has cut down a lot on people sort of signing up, working a couple shifts, and then leaving, before we put them out into the actual working pool. We have had a couple situations, and we basically told them, yeah, you're more than welcome to see your patients here, except they are seen as late after hours patients. You collect your hourly fee, and we collect their copay and billings. Yes?
Two-part question. One is about the hours.
Okay.
About 8-hour shift versus 10-hour versus 12-hour.
Right.
Is there one set that is more profitable than lucrative or will meet their obligations more sooner than the other? And the other part of the question is about getting the physicians from other facilities. Do you offer higher salary, or what do you offer to make them?
Okay. I've looked at a combination of salaries and patient complaints and things at our company. I'll tell you this, there is no correlation between what we pay a doctor and how satisfied the patient is. Some of the doctors that we pay the highest have the highest rate of patient complaints. Some of the doctors that we pay the lowest have the lowest rate of patient complaints. There's no correlation. What we found is that the doctors that are more intrinsically satisfied with what we're doing, they seem to be the happiest. We don't necessarily have to pay them a lot more. It's the ones that we have to reach and say, oh, well, we don't normally pay this rate, but we will for you. The ones that are just jumping around looking for the highest paycheck seem to have the most problems with them. Does that sort of answer your question? About the hours. Okay. Again, we're sort of in a unique situation because we've tailored our hours to our patient demographics. We've noticed that our clinic by LSU serves a particular hour subset. We have clinics that are open from 9 in the morning to 9 at night. I would say that tends to be sort of your general hourly model. And then we have some clinics that because it's more of a residential community and everyone's off to work in the daytime, we're open more late afternoon and evening. We have some clinics like at LSU, which the kids are in class from 9 to 1, but then they'll come in at 1 to 9, or they miss class and they want to come in and get an excuse because they were hungover, and they'll come in between 1 and 9, and then they want to go partying after 9 again. So again, a lot of this you have to sort of look at with your own demographics.
Do you have any facilities or physicians that you pay on a percentage base of collections?
No, we do not. I mean, I think there's an early question about some of our site managers, lead physicians. Yeah, it's all hourly with a couple people that do get bonuses based on, because the problem with our clinic is that we, as I had explained earlier, is we sort of rotate all of our physicians around. We haven't found a good way to keep certain people at certain clinics except for what we call our lead physicians. And they're really the only ones that we have the ability to calculate, from year to year, whether your revenue increases and things like that. Because, when I have a doctor that rotates amongst all 11 clinics, it's really hard to know what he has contributed to that location.
Or a productivity bonus?
We've talked about that.
More productive, more efficient?
Exactly. We've talked about that. And again, I actually just had a meeting with my boss within the past month or two, and we looked at different ways to do that. But as currently, we do not.
Do you compensate your providers who stay an hour late to see the 3 patients?
Yeah, that's a good question.
And also, for the inefficient, slower providers, you pay for them to chart? Let's say they saw 50 patients and they require 2 additional hours.
We pay by the hour. So from the time you walk in the door to the time you leave, you get paid. And we found that, that's just how we always done it. And I've talked with people like my wife. She's a pharmacist. She gets paid a salary. She's always pissed when someone comes in right before they close, and she just wants to get them out. I found that at least when you pay hourly, the doctor feels at least they're getting something out of it. And I think your second question was charting. We expect that the charting to be done in the 3 to 3.5 patients an hour. And very rarely, if for some reason there's just a large number of patients, we'll say, okay, fine, you stay 30 minutes an hour, finish your charting. But it's not something we really want our providers to do. Yes?
Do you require providers to establish a corporation?
No. For like the employees, we just hire them as employees, and then the independent contractors, we just pay them directly to their name. I don't honestly know to that level of detail, to be honest with you. And again, that might determine based on the state that you're in too.
One of the slides you wrote, consider non-compete if blocked by your jurisdiction. Just hoping, could you explain that a little
Oh, okay. I'll be honest, I've even forgot why I put that in there. But yeah, right. I guess that was what I was trying to say is, in some states they allow you to put a non-compete in your contract. So if you find a really good doctor, that's one way to keep him sort of attached to your practice. Exactly. But I've had some doctors that were really good, and the instant we suggest that, they're like, okay, sorry, see you later. So again, it's sort of a double-edged sword. If you find someone that's really good, that's willing to sign that, that's good for you. But if you find someone that's really good, because they're so valuable, they can find jobs elsewhere. The instant you bring that up, they may say, no, that's sorry. So that was I guess that was the point I was trying to make. Yes, ma'am. No, that's for physicians. I've been called by some staffing companies that will pay me $65 an hour, and I say, all I'll say is that's less than what I make now, thank you very much. And I've had some that go the other extreme where they're more higher acuity. So they see they're sort of an urgent care / ER where they might have CAT scan and that type of stuff. Or they just see a lot of patients, and that's where I've heard on the higher end of the range. But 65, yes, I've legitimately heard that for doctors. Yes?
I'll be starting my own urgent care. Just starting out, so I will be practicing there, but definitely I'm going to need some help after hours, after 6 or after 5 and on some weekends.
Right.
How many physician assistants at a time MD can supervise, or how that rules, and state-specific rules?
It's state-specific. For Louisiana, for example, you can have as many PAs as you want affiliated with your license, but you cannot supervise more than 4 at a given moment in time. So that's very state-specific. I think you need to think more of your general staffing. How many shifts can you reasonably work, and how are you going to fit in all these other people to make sure someone that wants a certain number of hours that you can give it to them, and you're not hiring someone and telling them, you can give them 30 and you can only give them 25. And again, if there's any situations where, I guess with you, you're different. You're a doctor. I would say, yeah, you could consider a nurse practitioner to work while you're not there, but keep in mind, you still need to be available to them. So it may not be as good a deal as if you just hire a doctor that can work independently. So you're not getting all these phone calls. Hey, I got this patient with chest pain. I don't know what to do. Oh, I got this other patient. And you're trying to, take a break at night or something. I don't know that question. We don't have that at any of our facilities. So I think I just mentioned that when she had a question of who gets paid $150. Some clinics that have those capabilities, they'll pay their physicians more. Great, thank you. Any other questions? Great, thank you very much. Pleasure to speak again here. Thank you.